Actually, the next session is the discussion on the frequently asked questions on the second generation TKI, but still we are yet to use in our common clinical practice. So probably before the, rather than that, some of the questions in the chat boxes we can discuss, followed by the questions. If it is arising, then we can proceed. I'll start with the questions in the chat box. The first question is from Dr. Roshni. Is angioplasty or recent angioplasty is a contraindication for BTK, either temporary or permanent?
Not specifically. I mean, I guess the issue with the BTK inhibitor really is the risk of bleeding, right? I mean, that would be something, you know, if you're on double anticoagulation, aspirin and Plavix, and then you add a BTK inhibitor on top of it. So I personally try to avoid either a dual antiplatelet with BTK or aspirin and an anticoagulation, like oral anticoagulation with BTK. So if you have a recent stent and the patient is on aspirin and Plavix, so that's something I personally would try to avoid, because at least in the United States, we have venetoclax available for these patients, so we should be able to use that rather than to subject them to the risk of bleeding complications. I would say that before the venetoclax was approved or was routinely available, you know, we were using dual platelets with the Ibrutinib at that time, but again, the risk of bleeding remains. So I don't think there is a contraindication per se, but I personally would try to avoid if the patient is going to be on a dual antiplatelet agent.
So in the context of the bleeding manifestations, what about the newer anticoagulations? Suppose keeping aside the antiplatelets, if it happens to be a single antiplatelet with the dual anticoagulations or any other anticoagulation alone, what is your choice on that?
Yeah, so, you know, again, before venetoclax was available, you know, there was no other option for us, right? I mean, in that case, we were putting these patients, if they were on aprixaban or rivaroxaban, and they were on aspirin, and then because that was the only thing available, you know, BTK inhibitor. Now that there are choices, I personally would avoid in my practice to put a patient who is on anticoagulation, this is my opinion, on a BTK inhibitor, just because the risk involved is there, and we have a potential safer option of venetoclax. Now, if you have a patient who has failed venetoclax or somehow has high creatinine, significant amount of tumor burden, you are worried about tumor lysis syndrome, I think it's okay to use, realizing that there will be a higher risk of bleeding for those patients. But let's suppose in the context of India, if you have for some reason availability of a BTK inhibitor for a patient has deletion 17p, yes, I mean, I think risk benefit that patient, even if they're on anticoagulation, you proceed, because that's what really the best therapy for that patient is. BR or something is going to lead to a short lasting remission. But if you have options available, if I have a choice between a venetoclax in that situation, I would say go with venetoclax, because why to subject a patient to a potential complication when you have venetoclax, which doesn't have that issue.
In that case, if there is only BTK is available, if acalabrutinib started getting available, will you prefer over that because of the less bleeding risk and other things? Even then, the risk is still.
Yeah. So I mean, I in my practice, you know, I have actually stopped using Ibrutinib. I have not prescribed Ibrutinib for the last couple of years since acalabrutinib came to the market. So if a patient, so really the options I discuss with the patient, I tell them, yes, there is Ibrutinib, but it's a more side effects, more atrial fibrillation, more dose reductions. And so I have not prescribed Ibrutinib myself for the last couple of years. Everyone who wants a BTK inhibitor is getting acalabrutinib. So yeah, so if it's a clear choice of a BTK inhibitor you want to use, I don't see a real reason that, I mean, and if you have access to both the drugs and everything is being same cost and whatever access, there is no reason to use Ibrutinib. Patients should receive acalabrutinib because it's certainly a safer BTK inhibitor.
Thank you. The second question is from Dr. Rajesh. Even though you have stopped using for the last 2 years Ibrutinib, we are still in the Ibrutinib era because of the financial constraint. So what are the most important causes for the Ibrutinib discontinuation? Is it the grade 1 events like simple musculoskeletal events or the severe ones?
Yeah, I mean, so I think obviously the grade 1 and 2 events are common. So majority of the patients will have arthralgias, myalgias, so those typically, I would say, doesn't lead to discontinuation of ibrutinib, but can lead to dose reductions. So you can drop to 420 to 280. I have many patients on 140 as well, few occasional patients on 70 milligram daily as well. So you can manage those grade 1 or 2 side effects by dose reductions. Rarely, I would say that those grade 1 or 2 side effects lead to dose discontinuation. The main reason for discontinuation has been, I guess, atrial fibrillation, severe infections where patients is getting into, may not be related to ibrutinib per se, but I mean, if suddenly someone has a fungal infection, which have been associated with ibrutinib, PJP, all those things. But atrial fibrillation, I think, is something which is a common reason for ibrutinib discontinuation in the clinical practice, because that also then, if a patient does atrial fibrillation, then they may be on an anticoagulation for their AFib. Then that adds another layer of this discussion we were having, where then to reintroduce ibrutinib, you may be having more episodes of atrial fibrillation, and then the patient is also on an anticoagulation, and then you are increasing the risk of bleeding. So in those situations, I myself these days, if a patient develops atrial fibrillation, and many times if the patient has been on a like 2 or 3 years remission, they're doing well on ibrutinib, their disease is beautifully controlled, I actually just hold their ibrutinib and see what happens. And you can actually, there are studies being done now that, if because I have patients, and a lot of us have patients where you have done ibrutinib for a certain number of 1 or 2 years, 3 years, a patient develops a complication, you stop it or hold it. You see the patient a month later, they're fine. 3 months later, they're fine. 6 months, and that can go on for a few years. So what I'm trying to say is that if a patient develops a complication, if the disease is beautifully controlled, I may just hold it, see what happens. But if the time comes that we have to resume the drug because their disease is flaring up, I may consider again a venetoclax-based strategy in that approach. You could reintroduce ibrutinib certainly, or certainly if I reintroduce ibrutinib, I will lower the dose of the ibrutinib in that situation.
Thank you. In the same context of atrial fibrillation, incidentally, on a routine clinical practice, we detected the atrial fibrillations, and the patient is absolutely asymptomatic, and the cardiologist have been called for, and they have added on rivaroxaban to make us complicated, and the patient is asymptomatic through and through for the next 1 week. The question is whether to reduce the dosage, whether to continue the medication, stop and restart, and the rivaroxaban in an asymptomatic patients.
Yeah, so that's a tricky one. So I think in that situation, the guidelines will say for the first episode of atrial fibrillation, you reintroduce at the same dose. If it happens again, then you lower the dose to 280. If it happens again, you kind of 140. In my practice, again, what my practice was, I would say, when we're using more and more ibrutinib, is that even with the first episode, I will drop the dose to 280 milligram. Now that decision may also come into play. Let's suppose a patient is within the first month or 3 months of their treatment, and they had a significant amount of disease. Maybe there is some concept of maintaining the dose intensity early on before you kind of drop the dose, because as you may know, there have been a lot of data of lower doses of ibrutinib maybe equally effective and things like that. But there is something to be said about the dose intensity early on. So if a patient had atrial fibrillation early on and lots of disease, I may resume the same dose thinking that maybe the disease needs help right now with the full dose of ibrutinib. But let's suppose patient is 1.5, 2 years out of it. Their disease is very great partial remission. They develop an atrial fibrillation. Then I'm much easier to drop the dose to 280 because I know that hopefully their disease hopefully they don't need that much ibrutinib. But that's just there has not been a head-to-head trial, nor there ever will be, of a lower dose of ibrutinib versus standard dose of ibrutinib. But I think those are some of the things I think about.
Thank you. One of the questions is regarding the MRD from Dr. Deepthi Rani. What is your opinion on the Activate trial having a joint MRD in the peripheral blood as well as in the bone marrow? Is it both combination is required because the concordance around 86%? So what is the inference of?
In the Captivate study, you said?
Yeah, that's correct. They have mentioned,
Yeah.
Dr. Deepthi has mentioned that. Activate. Probably she mentioned Activate.
Yeah. So MRD, I think is really, it's still a big debate whether MRD has role in CLL or not. Certainly, it has no role in if you're using Ibrutinib or Acalabrutinib, there is no role for checking MRD because these patients will never become MRD negative. You're just, it will always be positive. MRD can only come into play really if you're using chemotherapy or you're using venetoclax-based therapy, whether it's venetoclax plus rituximab, venetoclax plus obinutuzumab, or if you're using venetoclax plus ibrutinib, which unlikely, at least right now, you'll be using in Indian setting. And there, the question is, which is a better disease site for MRD monitoring? So what it appears so far is that if you're using chemotherapy, it appears bone marrow is definitely a better site than blood for MRD monitoring. But if you're using venetoclax-based therapy, the concordance rate is 86 to 90% range, which is actually a pretty good concordance range. And certainly bone marrow, doing a bone marrow MRD assessment, all those things, invasive procedure. So I think the field itself is moving towards a peripheral blood MRD for evaluation rather than subjecting the patients to bone marrow. A CLL14 study, most of the treatment decisions are when they stop the therapy at 1 year, and all the data they have shown about MRD and then subsequent progression is really based on blood MRD monitoring. At our center, we do much more bone marrow MRD monitoring, but more recently, I would say in the last 1 year or so, we are shifting to also using more and more peripheral blood MRD as opposed to doing bone marrow MRD, because I think at the end of the day, peripheral blood MRD is quite, yes, you may miss few patients here and there, but on a practical front, this is not like an ALL patient where MRD presence is impending for disease relapse in the next few months. CLL patients with MRD, they do fine. They will do fine for the next few years. So I think there's a less of a, MRD has, in that sense, less of an important role as opposed to what role it has in B-cell ALL for that matter. So so we are using more and more blood MRD for patients as opposed to bone marrow MRD.
Okay, so thank you. Dr. Mukesh question on the MRD has been addressed very clearly at this point of time. So Dr. Deepthi again asked this question on the hepatitis B flare-up in the Acalabrutinib.
We routinely check hepatitis. This is part of our standard practice to check hepatitis, HIV for patients starting any therapy of CLL, not just Acalabrutinib, venetoclax, antibody therapy, CD20 antibody therapy, chemotherapy. So certainly there has been reports of flare-up in the context of, I'm not sure if, I'm sure there are reports in the context of Acalabrutinib, but there are certainly reports in the context of Ibrutinib, obviously in context of rituximab, obinutuzumab, that if you have active hepatitis, it could flare up. If you had a previous exposure to hepatitis, it could reactivate. So there has been this thinking of, using prophylaxis for hepatitis B with the Anticoagulation and things like that for these patients. So I think certainly that's something you should check in your practice before you're starting Acalabrutinib for your patients.
Okay, so Professor Dr. Pranab Kumar Bhattacharya from University of Calcutta asked two questions. One is regarding the inheritance. That is, does hereditary factor plays a role in the etiology of the CLL for the first degree relatives? And the second question is, the several large studies showing the genetic alterations in the CLL, including the SNPs, chromosomal alterations, and the alterations in the non-coding RNA and microRNAs, some of which can be used to determine the prognosis and to guide the treatment strategies. View on yours.
So in terms of the familial CLL, this is a topic which has been studied to some extent, but not a lot of work has been done. There's certainly a slightly increased risk in the first degree relatives of having CLL, but it doesn't imply that you should be screening family members with a flow cytometry in the peripheral blood if someone has CLL. That is not the practice. The risk still remains very low. There are certain mutations, SNPs, which have been described. There are certain mutations like a POT1 mutation, which has been associated with familial CLL. So yes, I guess, but at the end of the day, I think it's not something I personally have not investigated much, nor that most most centers are doing right now to look specifically at familial CLL, as familial MDS and all those other things have gone along in terms of the research paradigm. And yes, so there are mutations which have been described in the introns and the non-coding RNAs and other things. Some studies have shown that they have some prognostic implications. Again, on a routine practice, on a clinical practice level, um, we are not doing those studies, and most centers are not doing those studies to look at the mutations in the SNPs or mutations in the non-coding non-coding regions of the genome. But again, those are things which eventually will be done. But from a clinical standpoint, I don't know what their relevance is. The only mutation I would say which really matters from a clinical perspective right now is the TP53 mutation. But certainly there are other Notch1, SF3B1, BOG3. Those also we routinely check for our patients. But again, this on a treatment decision-making standpoint, what really matters is the P53. Everything else, I mean, we check it, but we don't really make decisions based on Notch mutation, for example, per se.
Thank you. Last couple of questions. One is from Dr. A.K. Tripathi. What is a safe platelet count to start the Ibrutinib therapy? And from Dr. Vinayak, another question is, how common Richter syndrome in CLL? I don't know, he didn't mention any, whether it with BTK or without BTK. These are the two questions.
Yeah, so the safe thing with platelet, I would say that the clinical trials which have been done, I think the cutoff they have used many times is 25 and 30, something like that. But certainly if a patient has a platelet count of 10,000, I probably will not initiate Ibrutinib right at that time. For that patient, if you have to think maybe it's ITP or something, or if it's just the disease related, probably give Rituxan or Obinutuzumab steroids, try to control the disease a bit better before you initiate Ibrutinib and get the platelet count up. I would say at least 25, 30 range before you initiate Ibrutinib for a patient. In terms of the Richter syndrome, that's a big topic in itself. So occurs in around 5% of patients with CLL. It's a tough disease. Median survival is less than 1 year. Historically, chemotherapy such as R-CHOP, EPOCH-R, those have been the standard to use. We are now using venetoclax, as venetoclax is being used for everything else. We are using venetoclax now with chemotherapy. So we have a trial with EPOCH-R-VEN. Also, we have a trial with R-CHOP-VEN. We also have a trial with venetoclax plus a checkpoint inhibitor. We have done some work with Ibrutinib plus checkpoint inhibitor, which have been published. So I think these are the patients which are a tough scenario. I think in the context of India, you probably will end up treating them like a DLBCL, give them R-CHOP. But I think adding venetoclax probably is a good way to go for these patients if a patient can afford it. And then the goal should be an allogeneic stem cell transplant. These remissions don't last long. So I really should, if a patient is of transplantable age, to go for a transplant in this setting.
Thank you so much. Thank you so much. And we come to the last session. That is the expertise management of the CLL in a case-based discussion. And if Dr. Nitin, if your time permits, please join us and enlighten us in our knowledge. And
can I?
Thank you. And anytime yeah, go ahead. Go ahead, Chipsy. Go ahead.
I just wanted to ask Nitin two practical points that I just wanted to know from him. One, it is intriguing that you've all moved away from chemoimmunotherapy, while we are still, that is the standard of care here primarily. I just wanted to know, in case like when we have the steroid unresponsive autoimmune complications, in that scenario, is there a preference of which drug to use other than your deletion 17p and all that amongst the chemoimmunotherapy versus BTK or BCL2? What would you prefer?
So I would prefer a BTK inhibitor. I don't know if there is much data with venetoclax in that setting in the context of immune hemolytic anemia. I typically do steroids. I generally do steroids and rituximab together for these patients. If it's a first episode, you do steroids, rituximab, they generally improve. And I just watch them at that time. If it recurs 6 months, 12 months down the line, in that situation, I do steroids, rituximab again, get their disease control, platelets count up or hemoglobin up, and then start them on a BTK inhibitor. And again, it could be either Ibrutinib or acalabrutinib for that matter. I haven't used venetoclax in that specific situation. I don't know if there's a data with venetoclax in that situation. So I have more experience have been with Ibrutinib or acalabrutinib in that role.
Thanks.
Thank you. Anybody else is having any questions?
So when you
probably
place
just want to let you know.
PI3 kinase,
Yeah.
I will. So I have to leave in a few minutes. I have another competing call coming up shortly. So you guys can carry on, but I may switch off.
Yeah.
But
Anytime in between you can lay off. Thank you very much. Hoping that to see you again in our online meeting, if not possible in person, in the near future.
sure, absolutely looking forward to it.
Right. So
and maybe I can answer this quick question someone asked about the PI3 kinase inhibitor before I go. So PI3 kinase inhibitors, the role has become quite limited. You know, the efficacy has not been as great as a BTK inhibitor or venetoclax. And so we have, and the side effect profile, you know, is with immune colitis and whatnot. So we are actually using it really as a third, fourth line options after they have failed a BTK inhibitor or failed venetoclax. If they're not going for a CAR T for some reason, then that's the option we may consider. But you know, I think it's the role is extremely limited. I have very rarely actually used PI3 kinase inhibitors. All right. Thank you, everyone. I'll switch off. Have a good night. Stay safe. Bye.
Say something.